So I decided on maybe like traveling with you through a pregnancy very quickly. This is not going to be the normal 9 to 10 month affair that an actual pregnancy is. We're just going to sweep through it in a half hour or so, which doesn't give enough credit to what it is. But, I just, as a primer, I think there's some value there. And also I thought, well, what's the best way to do it? Let's just do this. Let's use a timeline. Let's start from the very beginning and we'll work our way to the end, right?
Yeah,
so starting off, with pregnancy, I think that, and I'm going to tread lightly as an individual who's never been pregnant once in my life, discussing the topic, and I want to give it the sensitivity that it deserves. I think when people become pregnant, or even before they become pregnant, the first conversation that needs to be had is probably about prenatals, and I can imagine, it tends to be tough for people. This is the worst pun, a tough pill to swallow. It's a tough pill to swallow, that someone has to take a medication daily in life in general, whatever that medication is. But I think if people know the value of taking the medication or the supplement or the vitamin in this particular case, I think it becomes easier from a compliance standpoint to get people excited. Maybe not excited is the right word. Once again, I'm treading lightly. I've never been pregnant. But to get people motivated and to really understand why they're doing it. So what is the reason that that gynecologists recommend taking prenatals? How long does a woman have to take a prenatal before she's planning on getting pregnant, taking it throughout the pregnancy, taking it after the pregnancy? If you can just give us a quick primer on that.
Yeah, so very good point. So if we have a person that is trying to get pregnant, ideally the patient should start taking prenatal vitamins at least 3 months before they conceive. And the main reason for this is because we want to build up the folic acid levels in the patient's system, because it's the way that we can decrease the chance of developing a malformation on the baby that's called spina bifida. So the folic acid that these vitamins contain is well known to decrease the risk for this malformation that can be devastating, because if it were to happen, then the spine is damaged, and it will cause the baby to sometimes lose mobility of the lower extremity of the legs. So if a patient is actively trying, that is one of the main benefits. So vitamin D in general also has been found to decrease the risk for preeclampsia. So sometimes we can actually add a little bit of extra vitamin D on top of the prenatal vitamins. If there is a safe dose that is recommended by the American College of Obstetrics for vitamin D. So it's important to note that higher doses of vitamin D could cause problems in pregnant patients. But we would discuss this with the patient at that time if she has a higher risk for preeclampsia, depending on her risk factors, or if she does have a history of having had preeclampsia in the past, she might benefit from vitamin D. So not everyone needs to take additional vitamin D, but at least for the prenatal vitamins, folic acid is paramount to decrease the risk for this. And as you mentioned also, given that the first weeks of pregnancy is when the baby is forming, is more important. So the first 14 weeks of pregnancy is when the baby is being formed. After 14 weeks, the baby is completely formed, either satisfactorily or with a malformation, right? So, and unfortunately, it's when the patients have the most nausea. So we see a lot of patients saying, yeah, I know that I have to take my prenatal vitamins, but when I take them, I just throw them up, right away I have a vomiting episode. So what I found sometimes is that if the patient cannot keep down the whole prenatal vitamin, it's better to sometimes try the folic acid only, because it's a way smaller tablet, and that is the one that has the most data behind it. So if you can take the whole prenatal, it's great. But if for some reason the patient is so nauseous that she's not being able to keep it down, we can either try gummies. Sometimes prenatal gummies are better tolerated than the tablet. And if they don't tolerate the gummies, then we can sometimes try just the folic acid.
Now, I guess a follow-up on that is that I feel like maybe some of the confusion is, there's, I think 400 milligrams. I don't know the dosage once again. Not a gynecologist, and also not a female who's taking them, and there's like 800, there's different dosages for them. And there's also, I mean, if you walk into any like pharmacy, it feels like there's a wall of varying brands and dosages. And I just feel like I'm getting dizzy looking at them. And I feel like that could be a source of confusion. Is there any way to like simplify it for people so that it's, once again, there's a medical disclaimer before this podcast, everyone should seek, care from a qualified physician and get their specific recommendations. But in generalities, is there any difference between the two? Who should take what, once again, in the most general terms?
Yeah, and that is a great question too, because I am sad to see that how the pharmaceutical companies make a fortune from these supplements, right? And then you can find prenatal vitamins that are $30 a bottle when like the most inexpensive is like probably like $4 or $5. And they are all FDA regulated in the amounts that they are that they need to contain to be called prenatal vitamins. So, but just because they add a little bit of more iron, which is negligible, and it's basically not gonna get absorbed, they triple the price. So I always tell my patients, just buy the least expensive prenatal vitamin that you feel that you can keep down. So you can go, I can prescribe you a specific one, or you can go to the drugstore, go to the prenatal vitamin section and find the cheapest one that you can tolerate. And that is surprising to many patients, because they really feel that I might get the most expensive one. And there's really not a lot of data that says that because it has a little bit more iron, it's just marketing, So the short answer is the cheapest prenatal vitamins that you can take and keep down.
It's awesome.
Yeah.
I love that, because just once again, in medicine, first of all, there are unfortunately things that cost a tremendous amount of money, and there are good reasons why some things cost a lot of money. And I think there's probably a natural bias. Something costs a lot of money, people assume it must be great, and that's not necessarily true. And I think that we validate ourselves as clinicians when we're able to go these cheap routes that are just as effective and save the patient's money. I always say like this: money is a zero-sum game. Literally, you have it or you don't have it. And if you spend your money doing activity A or on medication A, you can't spend it doing activity or medication B, which may be more vital for one's health or one's lifestyle. And we're the ones seeing the patients. The pharmaceutical company is not seeing the patient. They can decide whatever they want within reason, I guess, or maybe not. Once again, I'm not part of the FDA. I don't do pharmaceuticals, but they can charge a tremendous amount of money for something that essentially it could be a quarter of the price that someone else can provide you the same exact content, but it doesn't have the glitz or the glamour of that other company. And once again, it preys on the fact that patients will assume the $90 drug is better than the $20 drug, and that's not always the case. Probably something that deserves a shout out in this podcast, I haven't mentioned it before, is there's an app called GoodRx. I don't know if you've heard of it, used it, but I think, I don't know how they make money or what they do exactly to do that, and how they're able to do this rather. But they're able to give patients an understanding of the local pharmacies and where to get the medication the cheapest. And the reason I'll give them a shout out on this podcast is because, once again, the thing that is going to be the best by the patient is the thing that should be valued at the highest. And if you're not the clinician taking care of the patient, sometimes the priorities are different, right? Pharmaceutical companies' priorities is to ensure that they have the best profits and shareholders and that kind of thing. And the clinician's priority, a good clinician, is like, I want to do the best thing by you, but I also want to save you money. I don't want you spending, I'll give you another example for that is in my world, if someone has a bad otitis externa, a bad outer ear infection, sometimes you want to give them a little bit of a steroid, you want to give them a little bit of an antibiotic. There's a medication that goes by, I don't know if this is the trade name, but there's a medication that combines an antibiotic and a steroid. I've heard from many people that if you give this joint medication, some insurances, it's hundreds of dollars for them to pay for this medication. If you give the two medications separately in a different way, they could be spending $10, $20, and that's a massive difference, especially when you're talking about working in a potentially an underserved community or an economically suppressed community that, why should they get a worse medication because they can't afford? I mean, who should be able to afford a $300 drug? But they should get just as quality an option and care, and they shouldn't be, once again, you shouldn't say like, sorry, this costs $300, I can't do anything else for you, right? So it's awesome to be able to have these low cost options for patients that are just good as other costs, as other medications rather. Moving on in pregnancy, so someone's, let's say, 6 to 8 weeks, right? Once again, everyone should go get their general advice from their general physician. But let's say a woman has, is 8 or 9 weeks pregnant. She starts having abdominal pain, maybe even some vaginal bleeding. What, in general, what should be their next steps in that case?
Yeah, so what we will recommend is to seek medical attention, but depending on how brisk the bleeding is, it will be the acuity of the attention. So if it's spotting, I would recommend they call the doctor's office and let them know what's going on, and then the provider will determine if the patient needs to be seen the same day, or if they want to do some blood work to see what her pregnancy hormone is, and order a sonogram. If the bleeding is brisk, then patients sometimes might need to be evaluated in the emergency department to make sure that they are not unstable from the amount of bleeding. There can be different reasons why a patient bleeds in the first trimester. Sometimes it could be as simple as what we call implantation bleed, which is when the baby is getting attached to the uterus. The placenta kind of like erodes the wall of the lining of the uterus, and that could cause a little bit of bleeding. But sometimes it could be a sign of a threatened abortion. And
threatened abortion is essentially, in colloquial terms, a miscarriage. I think that's what people generally...
It could be not a miscarriage itself. It could indicate that you could be having a miscarriage, right? Because patients with a threatened abortion sometimes might continue to have a successful pregnancy. But in the first trimester, regardless, even if there's no symptoms, we recommend doing a transvaginal sonogram to determine the weeks of the pregnancy. But if the patient is bleeding, then that sonogram might need to happen sooner than expected. First of all, to determine if there is a viable baby that we can see in the uterus, or we can sometimes say, oh, it's too early, we don't see anything, but that doesn't mean necessarily that there's something wrong. We might need to give it a little bit more time. And in that scenario, usually having the pregnancy hormone level is very useful, because usually we need it to be at least 3,000 for us to expect to see something inside the uterus. If it's less than that, then we cannot say that this is an abnormal pregnancy. It just might be too early,
Yeah. I mean, that's, first trimester vaginal bleeding is something near and dear to my emergency medicine heart, because it's something that we don't infrequently see in the emergency room. And, it's those are some tougher encounters, because generally speaking, it's at night, because in the morning time, they're able to get their appointments with their obstetrician, their gynecologist, so they're with a familiar face in a comfortable environment. And at night, the nighttime's a scary time to begin with, and they're in a foreign hospital. Maybe they haven't been in that emergency room before. There was so much tentative excitement about this pregnancy, and now there's worry and concern. And it can be a very stressful time. And from an ER standpoint, we're doing the basic blood work usually, making sure they're not bleeding too much with the CBC, maybe checking electrolytes, kidney function, that kind of stuff. And then we'll oftentimes, if we can't see anything, draw the beta-quant, that pregnancy hormone that you were speaking about. And we have a sense, we do a transabdominal ultrasound if there's availability or the capacity, a transvaginal one, to see if we can see the early signs of pregnancy. But it can be a harrowing moment. It can be very tough for family, especially if there's difficult news based off of the evaluation. But once again, those to me are the clinical encounters where we're needed the most, right? For the average minor encounter, I don't remember who said this, but someone said, God forbid, let's say that person ends up losing that fetus, that baby in utero. they always remember it. Women always remember like, oh, they have a certain amount of kids, but they also know how many miscarriages that they've had, because those matter to them, because at the time, that those were dreams and expectations that didn't come to fruition. So, it's a time for me to pull up a chair and have a conversation and say, this just happens and this is not your fault. And sometimes it's the genetics were not strong enough for the pregnancy to hold. And, once again, it's framework. And if you frame it the correct way, you can give someone at least an early sense of peace and solace. And at the same time, if you do it wrong, you can absolutely destroy someone, right? If you don't show that humanism and the emotion and compassion, and you look very rushed and you are very rushed, you do a cursory, very quick exam and quick evaluation and very bluntly say what's going on without care and compassion. I mean, I cannot imagine what that does to a woman and to her spouse at bedside too, when they get the news in not the most professional way. So those are the moments where you got to stand up and shine, right? So I appreciate your insight on what women should do in that case. Ectopic pregnancy, what exactly is it, and what does one have to do if it's something that they unfortunately would find out that they have?
Okay, yeah, so an ectopic pregnancy, by definition, is a pregnancy that is located outside the uterus. And it can be in different locations, but the most common one is a fallopian tube. It can also sometimes be in an ovary, although it's very rare, or sometimes even in the abdominal cavity, right? So when an ectopic pregnancy is identified with a sonogram, we need to counsel the patients that unfortunately will not be a viable pregnancy that we can continue to follow, because we will be putting the patient at risk of life-threatening complications. Most of the time, if you have an ectopic pregnancy and you know about it and you don't do anything about it, it would cause an acute abdomen from bleeding. It tends to cause damage to the structure in which it is located. Most of the time, as I'm saying, the tube, it can get to a point in which it ruptures and then starts bleeding heavily. And unfortunately, I've seen cases in which patients can have a large amount of blood in their abdomen, and get to a hospital very unstable. So depending on the size of that ectopic pregnancy, the amount of the pregnancy hormone, there are two main options for management. One can be medical with methotrexate, which is a medication that destroys the pregnancy without the need for surgery. But we have certain criteria that we need to follow to make sure that the patient is a good candidate for it. If the pregnancy is too big in the sonogram, more than 5 centimeters, or if the pregnancy hormone is more than 5,000, then the likelihood of or the risk for failure with medical treatment is higher. So it's not something that cannot be discussed, and some patients, as long as they understand that there's a higher risk for failure or a need for additional doses of methotrexate, they could choose that as long as there's no signs of active bleeding and unstable vital signs. But usually that's the cutoff. If it's larger than that, or if the patient is acutely bleeding, then the best management will be surgical. And we always try the laparoscopic approach, which is the one that you mentioned, with small incisions and a camera. Sometimes it might be necessary to make a larger incision if there is visibility issues from the amount of blood or things like that. But in my experience, always, most of the time, I've been able to complete a surgical treatment with laparoscopic approach.
Mm. Yeah, I mean, I think that the terminology ectopic pregnancy, it kind of is misleading in some ways, because there are women who I imagine would believe like this is a pregnancy like every other pregnancy, and I don't want to lose this baby, right? Yeah. And the reality is the baby is not in any way, shape, or form in an area where it can grow and be nurtured and 9 to 10 months later come out as a fully formed fetus ready to enter this world. It is in a, like you said, the uterus is the house for the baby, and it could be in the little tube that's outside of that house. And if it gets too big in that tube would, pop open, so to speak, and the bleeding, and it's extraordinarily dangerous. It's in no way or shape or form not a viable pregnancy. So like the term ectopic pregnancy, especially because we sometimes use all these very convoluted sounding terms, I think that sometimes it can be misconstrued of like, oh, I don't want to lose the baby, but there's no you're not capable of maintaining that pregnancy, and it's really a life-threatening condition. And certainly I've seen in the emergency room setting that people can bleed a tremendous amount into the abdomen. And that was, we did the exam and that was the cause. They have a positive urine pregnancy test, and there's blood in the belly. They thought they were pregnant, but unfortunately it was an ectopic pregnancy, and the blood pressure could be very low. There's no scarier moment than a young, otherwise should be healthy individual who is extraordinarily ill, maybe some would say even at death's door, in the emergency department. Those are the cases where everyone pulls together, and there's certain heightened level of job performance and expectation, because we care about everyone that we take care of, but those just humanistically get to you a little bit more. The younger the patient is, it's just kind of a natural knee-jerk instinct, I guess. But okay, moving on, second trimester checkups, right? Mm-hmm. I feel like the first trimester, there's a lot of uncertainty. There's a lot of the ultrasound, the beta evaluation. Is the pregnancy in the uterus in the correct place? Is there one pregnancy there? Are there multiple, right? And then I guess you get a sense. And then the second trimester kind of goes along, and maybe there's a formal 20-week ultrasound or something like that. But what is the significance of that second trimester of the checkups? What are there genetic tests that are performed? What is, what does the second trimester look like for most individuals?
Yeah, so first of all, once a patient reaches 14 weeks, that's when we call the patient to be in the second trimester. The risk for a miscarriage decreases significantly. It's not zero, but it's way less. So we always tell the patients when they reach the 14 weeks, congratulations, the risk of losing this pregnancy is way less right now. By that time, we already...
You don't have to work on B'Shah Tova.
Yeah. So, and by that time, we already did the initial prenatal blood work that checks for different conditions, anemia, any sexually transmitted conditions. We also check blood type for the patient that is important later in the pregnancy or in the case of bleeding. And we also usually offer genetic screening for the baby in the first trimester. And the one that is most commonly used nowadays is the non-invasive prenatal testing that can determine via a blood test from mom's arm without the need for any invasive needles on the mom's abdomen for the baby. It can check the chromosomes of the baby running through mom's veins, which is pretty amazing. And it can also, if patient desires, offer the gender of the baby. So that's usually optional, and the genetic screening is not something patients must do. It's something that we offer the patients. For the non-invasive prenatal testing, or NIPT, it can be done as early as 9 weeks, but it can be done all the way throughout the pregnancy. So now that we are in the second trimester, though, the goal is to take a look at the baby's anatomy via a sonogram, and this sonogram doesn't need to be transvaginal anymore, because now the baby is big enough that we can see most anatomical structures on the baby with a probe on mom's abdomen. And it's a very beautiful sonogram. It's a long sonogram, actually. It takes about 30 to 40 minutes. And the intention and the purpose of this is to check the baby's anatomy from head to toe, just to make sure that everything looks fine, that there is no signs of any abnormalities or malformations. And this is very relevant because if a patient is found to have an anatomic malformation, then these babies might need to be born at a higher level hospital. So some patients might want sometimes decline the sonogram because they don't see the value of it, seeing that no matter what the sonogram shows, I'm keeping this pregnancy, and we understand that, but we want to know if you need to go to a higher level hospital to have this baby, if the baby were to be born with a condition that needs immediate attention, like cardiac malformations or things like that. So there's a lot of value in it because it allows us to prepare in the case that we see that the baby might have something that needs a higher level of treatment.
Yeah, I think ultrasounds, and once again, relating back between our fields, not that there's not a lot of disagreement between OB and emergency medicine. I guarantee you there is a tremendous amount of that, and we can get into that in a later episode. I'm sure we will. But there's obviously a lot of symmetry and a lot of agreement overall. A lot of synergy. We work together pretty well a lot of the time. But with ultrasounds, there's like this duality there, right? So there's some of it we're doing for us and some of it we're doing for them. So it's, if I have a patient who happens to be pregnant and I'm evaluating transabdominally with an ultrasound, I need to know the basics. I need to know is there fetal movement, what the fetal heart rate looks like, general age, either, the BPD or the yolk sac size or the crown rump length. Like I've got to figure out these measurements to get a sense of how many weeks they are, right? Yeah. So those are my fundamentals, like are they moving, how big, fetal heart rate. And, then there's the for them aspect of it of like, hey, I want to see because it's almost like a chance to visit with the child that they haven't seen yet. So it's very exciting. When I'm curious how much of the ultrasound, so in this particular case, there are some groups of people that don't want to know because for them, it's not going to change the outcome. But what you're saying is, yeah, it's not going to change your outcome, but I would really like to know because instead of us telling you we're going to deliver here, you're going to have to deliver there. They're going to have to be ready to go, the second you're delivering, they're going to have to know to mobilize the team and get ready for it. And that's, once again, that's a tough situation to negotiate because of autonomy versus paternalism. So that's a tough situation. But also throughout pregnancy, I find that a lot of times, and I've been through this with my wife, where, do you want to hear the heartbeat? I have to think about this more before I discuss it on the podcast, but there's something about letting parents listen to a fetal heartbeat. I don't know if maybe it's the most tangible thing that you can do at that moment in time to make them feel connected to it. And maybe there's a sense of reassurance, but it's not always medically necessary for them to hear it. You just have to count and make sure the beats are correct and you're not worried about fetal stress or an issue there. But, definitely just maybe a soothing aspect to parents hearing it as well,
Yeah, definitely. And I always tell my patients, especially when they are hesitant to get the anatomy sonogram, I always tell them this is a beautiful test. You can bring actually your partner with you, and we try to accommodate for that because it's the first time that you can actually kind of see the face and sometimes the anatomy sonogram, you can, if the baby allows, depending on the position, also know the gender. If the patient decided not to get the non-invasive prenatal testing that gives you the gender via blood work, that's also a good time if they want to know. So there's also this recreational aspect to it that we also use to encourage patients that are hesitant about getting it. And as you said, it comes it's a combo, right? We want to get the information that we need to give the patient the best care possible, but also there's an enjoyable part of this, and we always try to make it enjoyable for the patient, especially and the sonographers are the ones that are working on that every day. But I've never seen a patient not smiling, right, when they're seeing their baby move or their heart beating. It's a beautiful experience.
Yeah, I mean, every form of medicine has its pros and its cons, and one of it in OB is the joys of that process, and it's such a low morbidity, relatively speaking. There's such joy, everyone's happy. I mean, it's one of the few times people are happy to show up in a hospital is because they need to give birth and they're doing it in a hospital setting. Yeah. Most times people show up to the hospital and it's for all the wrong reasons. So it is a really nice, enjoyable component to the field for sure. And I don't think this is evidence-based. This is anecdotal. I'm going off the cuff here with this one, but I think the harder it is to visualize the child during the sonography, that usually equates to a child that's going to come out and, he or she's going to give you more of a challenge. The ones that aren't positioned right and they got to turn and that, I think that definitely, this is not evidence-based. This is pure anecdotal evidence that I have an N of 3, a sample size of 3, God willing 4. But yes, I think that there is certainly a correlation how hard it is to get pictures of the child then, and how hard it's going to be to get pictures of the child in 5 years from then, you know? So
Yeah, I have to agree on that. Also, with my first child, she was so hard to look at, and then she's the one that is uh, the problem child, not the problem child, but the one that is more.
she'll watch this in 20 years. So
Yeah.
she's the one that's. I heard it like this. So this is Yochi can correct me if I'm wrong, but in this community, I heard the phrase, "You'd prefer to raise a chaya than a behema." You heard that one? So I heard this phrase from someone, and I can't advocate for it. I'm just saying what I heard from one individual. But the difference, both those are terms for an animal, but one is a domesticated, a behema, and one's undomesticated, a chaya. You know, they're a little bit more rowdy or whatever it is. But if you look at those kids in 50, maybe they give you a lot of gray hairs. Maybe people lose their hairs from them. But if you look at them down the line, it's generally those people that are movers and shakers. I don't know how many gray hairs you gave your parents, but you know that's definitely a terminology there. So. It's and it's always a blessing. So it's definitely unique. But so we're moving on through the second trimester. We went through that pretty quickly, thank God. Hopefully we've stopped having episodes of vomiting every morning. Hopefully that stage is gone. It's not for everybody. How common is that for people to actually have emesis in the morning, to vomit during the morning during their entire pregnancy?
It's not that common, but it's not unheard of. We unfortunately sometimes have patients that they just don't stop vomiting throughout the whole pregnancy, and then we have to even sometimes do these Zofran pumps for them to be able to administer medication at home in a different way than just the oral version. But fortunately, it's not that common.
Yeah. I mean, from an emergency medicine perspective, I see not infrequently hyperemesis gravidarum, or, that's fancy for just vomiting in pregnancy, as you said before, most commonly in the first trimester. And they're miserable, and they have to, they're basically starving. Essentially, it's starvation. Yeah. They have to get an IV, sugar in their IV, all these different antiemetics, vomiting medications to prevent them from vomiting, just to take them up enough to be able to continue with it. So it's tough. But anyways, we got through the hyperemesis. We've gone through the second trimester. We're in the third trimester. So I guess three main diseases that I would want to discuss quickly before we get to the end of this over here. But just so I give them all their credit and they can briefly, people should be aware of them, right? What is, these two are similar but different, obviously, placenta previa, and how does that differ from placenta abruption? I know these sound like magic words to people, so if we can break them down from their technical terms into what they actually are.
Yeah, so placenta previa is a term that refers to the actual location of the placenta within the uterus, meaning placenta previa is when the actual placenta is sitting on the cervix, either completely. The cervix is the outlet for the uterus, which will open for the baby to be born. But the placenta sometimes might be on top of the opening of the uterus, and that's what we call a placenta previa. So in that situation, it does have implications, because if the placenta is on top of the opening of the uterus, then vaginal delivery is not possible. It can be life-threatening, because there can be a massive bleeding for mom. So in these situations, we need to plan for a cesarean section.
And could you see where that placenta is on your ultrasounds beforehand? Or is that it's moving and you can't really figure out where it's going to end up?
Yeah, so initially you can identify it, but it doesn't become that relevant until we have reached the third trimester, because if you see it early in the early second trimester or in the first trimester, as the uterus expands to accommodate for the larger baby, then the placenta sometimes can move away from the cervix, and then it stops being a placenta previa. But if we repeat a sonogram, which we usually do here at 32 weeks, not only to check for the placenta location, but also to check the baby's growth, if by 32 weeks a placenta is still on top of the cervix, still a previa, then the likelihood of it moving away is very low. And that's when we start planning for delivery via cesarean section.
Placenta abruption, what is that exactly?
Yeah, placental abruption is a condition in which the placenta...
By the way, it's a nightmare for me, but obviously for the same.
Yeah, so the placenta is, as you know, attached to the uterus, and then it gets nutrients from mom's circulation to the baby. And placental abruption is when the placenta starts to detach from the uterus prematurely. You know, like when a baby is born, it's natural for the placenta to peel off the uterus, and then we deliver that placenta after the baby, and that's necessary. But for some reason, some patients might experience a partial or sometimes even a complete detachment of the placenta from the uterus when the baby is still not ready to be born. And this most commonly manifests itself with vaginal bleeding in the second or third trimester.
Yeah. So, I mean, my classic board memory for this is placenta previa is painless, vaginal bleeding, third trimester, obviously with how you mentioned it, with the placenta covering the os. And then, the abruption is when it kind of traumatically potentially is torn away, can be very painful. But both of those are things that an emergency room physician does not want to be seeing in their emergency room, because obviously those are situations that really require the hands of a skilled obstetrician at that point. And the last one is preeclampsia, something that I see not infrequently sometimes when I work. What is it? Is there anyone who's specifically at risk, and what is the treatment pathway for patients with preeclampsia?
Yeah, for preeclampsia is a condition that is exclusive to pregnant patients, in which patients start to develop high blood pressures, and also they start to develop a condition that's called proteinuria, which is basically peeing a lot of protein. So protein is a nutritious element that we should not be putting in large amounts in our urine, but preeclampsia causes a dysfunction at the level of the kidneys that allow for protein to come out into the urine. So these patients can get very sick. The preeclampsia is classified in severe or mild, and depending on how severe the preeclampsia is, then the recommendation is for delivery. So the only cure for preeclampsia is being delivered, not being pregnant anymore, because it's caused by the pregnancy itself. So we have to wait and balance baby's well-being and prematurity, because sometimes preeclampsia can develop early in the third trimester, and baby might be too young for that. So if we have severe preeclampsia on a patient that is very early in the third trimester, sometimes those patients, actually their recommendation is for them to be hospitalized and stabilized, to allow for a little bit more time for the baby's lungs to mature and other organs to mature. There are medications that can be given to what we call optimize the baby, like steroids, to help those lungs mature faster, for the baby to have a better respiratory response when baby is out. And if we have mild preeclampsia, then we can push that delivery time to at least early term, which is about 37 weeks. And the outcomes for the baby at that time are usually way better. So it does have a lot of implications, because it poses a risk for mom, obviously. Having high blood pressures, if the blood pressure is severely elevated, can pose a risk for strokes, hemorrhage. It can increase the risk for placental abruption, which is that detachment of the placenta from the uterus with bleeding. So it's a condition that we need to follow very closely, and depending on if it's severe or mild, severe needs to be followed in the hospital. If it's mild, then we follow those patients very closely with blood pressure checks at least once, twice a week, with blood work to check their liver enzymes as well, because it can also start affecting the liver, and you can see that on a blood test. So it's unfortunately getting more common nowadays, but in general, the incidence or the frequency for preeclampsia is about 7%, but I feel that if we look at data right now, it might be a little bit higher than that.
And from an emergency room standpoint, when we deal with these patients, the biggest, I guess, concern that we have in the acute setting over there is that if they transition from pre to just straight eclampsia, if someone starts to seize, to give them magnesium, but that's obviously a very stressful, tenuous, high urgency situation. So, not something that anyone wants to see, but it's important to be aware of, especially with blood pressure in later pregnancy. If there's any abnormality, that obviously women should know that they should see their obstetrician for an evaluation. Now we can say Mazel Tov, the baby was delivered. That was quick. It was about 30 minutes. So probably the quickest natural delivery known to mankind.